Greetings, I'm your host Hugh, a duly licensed behavioral scientist in California with an agglomeration of bizarre escapades for more than 6 decades of extraordinarily enjoyed, enlightening experiences on my earthly expedition. Welcome aboard this ship of fools. We, that being me and myself, hail the humor hullabaloo. This is the healthcare advisory for healthy healthcare workers working in healthy healthcare settings who want to stay healthy and keep their friends, family, and patients healthy. Today's topic. It's chronically, pervasively, ubiquitously in the news and in our lives. More importantly, how can we end this endless infiltration and get COVID-19 out of our face? This is your COVID-19 infection avoidance algorithm. First, some clarification. From here on, I will refer to COVID-19 simply as COVID, and although COVID actually refers to the disease caused by the virus, severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2, in this training at times I'll use COVID to refer to the virus itself. I also use the term asymptomatic to describe both infected individuals without symptoms who do not later develop symptoms, and infected individuals who are pre-symptomatic at that particular time. Infection control strategies come in a variety of situation-dependent formats. Due to the recency of COVID, we also rely on infection control studies of other diseases, as we just don't know enough about COVID yet, even though research is being performed, documented, and published at an astronomical pace. Per Kingsley and Wynne Van Tam, all routes of transmission, droplet, aerosol, and contact, have a role to play. Their relative significance will depend on the set of circumstances acting at a given time. Unfortunately, that astronomical gate generated virtually no viral gastronomical avoidance studies. So to get this thing out of our face, I'll talk specifically on eliminating unintended self-inoculation via contact transmission of the hand-to-face type. This will be based on available research reviewed, my experiences as a behavioral scientist personally trying a variety of contact reduction suggestions, and rapid analysis of the most promising practices. In spite of being a behavioral scientist, I am an unaware face toucher. Previously, I've been a disaster chaser and a consultant to advisors to 2 real presidents. Behavioral scientist is cool, but face toucher is not, except under certain pre-approved and desired conditions. Since hearing that a city of 11 million went into quarantine, I've been intently focused on infection control. I've been trying to be a better behavioral scientist by finding out how to stop touching my face. PubMed, WHO, and CDC say stop touching, but they don't say how. Google's contributions include wear glasses, wear itchy gloves, touch something else, keep your hands busy, intercept with out of stock tissue. Use foul-smelling nail polish or hand cream. Trim your nails or use bad-tasting nail polish so you don't bite them. Spend a fortune on a wearable face-touching alerter, complete with training. Get a face scratcher to use when you itch. Lace your fingers together. The most effective behavioral suggestion, exclusively behavioral suggestion, I came across was the Sharpie memory trick. The next most effective was using repellent to create an olfactory signal not to touch my face. With both of these, the strategy is to alert visual and olfactory memory just before my hand gets to my face. I tried them with some, but not complete success. I also made giant wrist flowers that worked somewhat, but were quite a pain. Strong essences, such as tea tree oil and eucalyptus, didn't last long enough. Of the smelling strategies, insect repellents work the best because they smell unpleasant and have a binder that makes them last longer. Hot sauce on my fingers was an instant fail for me, but might work if you hate hot sauce. I also found leaving handy hairbrushes available to scratch what itches helped. The face shield with sidewalls was the only 100% effective measure. The sidewalls really blocked my face touching. There was no fogging with or without a mask. This was the best solution so far. But is a mechanical barrier really a behavioral strategy to infection control? Absolutely. The behavioral strategy is to consistently put it on whenever social distancing and to consistently and carefully sanitize it when done. Let's have a quick review of the most effective to least effective COVID infection prevention strategies to put the hand-to-mouth interception payoff in perspective. The most effective societal behavioral control is social isolation. That is followed by social distancing with valveless masks and face shields on everyone. Less effective is social distancing with valveless masks and face shields on some of the people. Still less effective is social distancing without masks or shields on other people, but with a mask, valveless or not, and shield on self. Further followed by social distancing without masks or shields on others or self. Chased by the infection acquisition strategy of no social distancing, masks, or shields, rather movement towards the herd immunity concept.